It's lovely to be here with you all. 20 years, gosh, that makes me feel old. I'd never say that if I introduced myself, but anyway, great to have you all with us. We've got a fantastic hour, I hope, which I'm going to be sharing lots of kind of examples of great anchor practice that I've seen as I've gone around my various roles, and give a flavour of what we're doing at Imperial, and then also some of the things that I think really help make this work happen. I'm aware there's colleagues from a mixture of backgrounds on here, from the NHS, from local government, from wider than that. Some sit within our geography in Northwest London, some beyond. So it's fantastic to have so many of you here. That does make my job a bit harder, in that trying to work out who's the audience for this talk is more tricky. So it's going to be a bit of 101 anchors quickly at the beginning, going through some wide-ranging examples, and then having a chance to kind of delve into what some of that means a bit more. So I'm going to share some slides right now. The slides will be available online after this conversation. Sharma, I can't see anyone now, so can you just tell me if you can see my slides okay?
Yeah, they're there.
Wonderful. Okay, so a little bit of background about me. Why am I here talking to you? Well, I've been involved in anchor institution work for quite a while. I first got involved when I had a role at the Health Foundation, looking at what was going on in the US, and I'll say a bit more about that. But then also had a key role to play in helping to develop anchor institutions, sneaking its way in the last paragraph on the last page of the long-term plan for NHS in England, and then have been involved through various different routes in local anchor initiatives through my organisation at Imperial, and leading some of the sort of more bigger strategic pieces and thinking in that, and have also then been involved in trying to think about how do we really help people get this work moving through my role as leading a local anchor network across London with NHS London, England, and also going around the country, getting to be on road trips, looking at great anchor practice and helping others think about this. So that's the kind of background to how I bring all this stuff together. It's some lenses that look at international work, local work, regional, national, etc. And I'm planning to share some of that with you because I think it's really useful as a lens to help us think about how do we start to tackle health inequalities, and I'm hopefully going to show you some of the ways that anchors can do that. Before I do that, I just want you to reflect for a moment on what number you are on here, because for some people this topic's going to be quite new, so I'm going to be doing a bit of definitions and where the story started, for me at least. For some of you, you'll be doing quite a bit, and for others, you'll be thinking, God, I don't know why she's presenting. I could be the speaker here. In which case, I'd love to hear from you in the sort of question bit about some of your reflections or anything that you want to signpost people to around the amazing work, recognising that I'm definitely not an expert and definitely not the only one working in this space. So, where did this come from? Well, the work that I first got involved in was when I was studying this from a US perspective. There was a big time in about sort of 60s where the states in the Midwest were heavily industrialized, and some of that industry fell away, mining, etc., due to big recessions and changes in multinationals and where they were putting their focus. And this quote was quite striking to me. When the big industries were here, the communities weren't even seeing a penny of it. But when things declined, it was the anchor institutions that remained. And what was left in some of the places like Cleveland, Ohio, and others was organisations such as hospitals or universities that became the biggest employer, and often were there as the kind of left as the fabric within the communities. And so this notion of anchor institutions is really about organisations that are anchored and rooted in their communities. They're unlikely to relocate at short notice. They have a significant stake in their geographical area, and they're usually large. They have sizable assets, often being one of the biggest employers, spenders in the area, and can use this economic and social power to improve opportunities for people in the local places. Now, there is some contention about whether those need to be public sector or whether that can be private sector. I guess the part about how likely are they to relocate, how much are they really intertwined and care and have a mission that is something that they consider heavily with their local communities, and that's really what makes people anchors. What you see along the bottom is different icons of the types of organisations, often labelled eds and meds, so to speak, around being universities and hospitals, but not that at all. There is municipal buildings, cultural organisations, local government and others that are very much have that social mission, often very rooted in communities and big players. And what I don't like about this definition, although I was one of the co-authors of this report, I think it hides some of the things we're really trying to talk about, which are about how anchors can influence the conditions that the community find themselves in. And it's the ability to help transform the neighbourhoods, towns, cities and regions that our communities find themselves in, and really help uplift that. So some of the principles that sit behind anchor institutions are around community wealth building, thinking about making sure that there isn't just this trickle down approach in the economy, that employment and the local procurement benefits all, but particularly those who most need it, and thinking about adopting some of those community wealth building approaches. That said, when I was thinking about how we design some of the frameworks that sit behind anchor institutions, I felt that it was slightly too narrowly focused on some of the economic drivers and less on some of the social and environmental things that many of our organisations care about. And so when I was helping to build this framework with the Health Foundation, we snuck in a few extra things that included how do organisations better use their buildings, land and space, what's their environmental impact, and also how they work differently with local partners. So it isn't just about procurement, investment and employment, although those things are really important. And whatever sector you're working in, some of those will be more prominent for you, and we'll talk about that through some of the examples. There's just a little reference to this paper that we wrote quite a few years ago that helps give a bit more flavour to some of the stuff here, but this infographic has been used quite widely to help explain that. And what makes the NHS in particular an anchor institution, and that's the lens in which I come from, which is healthcare, so I'll be a bit unapologetic that quite a lot of my examples are around hospitals and healthcare, is all of these attributes: being one of the biggest employers, procuring billions of pounds worth of goods and services every year, being one of the biggest polluters in the public sector, etc. So how do we think about being more intentional about the things that we're doing and turn that around for more positive good in our communities? So health and care being one of the biggest employers, what that really means is, in some communities, for example, let's take Blackpool, one person in every family is likely to be employed in health and social care. Now, second to retail, it's a huge set of employers that exist around the country. That means that as an employer, we have a responsibility to all those people through the organisations in which we employ them. That directly impacts their health through the quality of work that we give them, but also in those families, they are the beneficiaries of some of that income, etc. So how do we think about our responsibility as an employer? And there's a number of ways organisations have been doing this, but an example here from University Hospitals in Birmingham, they set up a learning hub that helped to try and upskill people to think about what skills they need to take employment in organisations such as the NHS, and have got a huge number of people into work through doing that. And that's really about widening participation and building that pipeline. If you go out to schools and ask people what do you think you need to have a career in local government or in the NHS, the first thing people often say is a degree. And as many of us know, that's absolutely not true. There are some brilliant examples in other places around the country, for example, Leeds, who have looked across profiling their communities and looked at the demographics and said, where are our most deprived communities and how are we really going to go and target our employment opportunities to them? Any of you who've ever applied for a job on NHS Jobs knows you need massive qualifications just to be able to try and open the track portal and be able to upload into that. So these things can be a barrier for people. So how are we working out where we want our employment to reach and how are we building skills in terms of those people? Barts Health has done some amazing work in terms of that pipeline and have won fantastic awards around their social mobility employer index, so it's well worth checking those out. Many of our organisations do things like project search, widening work experience, etc. But some of these organisations have really been at it for a long time and have made big inroads across thousands of people, being really purposeful about who they employ. We at Imperial College had some amazing work that went on just before COVID, looking at how we insourced from being on temporary and 0 hours contracts. A huge number of our hotel services who are integral to the work that we do. And that's meant they've ended up getting the same benefits as other NHS employees, getting a pension, etc., which has been really, really important. Now, not all organisations have the ability to do that, but we were able to, and it's been a fantastic way to see how some of the quality of the work has changed for those people and indeed the outcomes for the organisation. I'll come back a bit to how we make sure we really think about, though, how we're looking after the different types of people that we employ and some of the schemes and the access they have once employed. But that's a really important way of being able to do that. Recognising that not all of you are responsible for huge, large insourcing contracts, but there are things you can do even just within your immediate teams. And here is an example from Royal Free Hospital in London, just north of where I'm based currently. They looked at their workplace health and wellbeing programmes and realised that only 10% of the staff accessing it were from lower paid staff groups, even though that made up about 40% of staff within their employment. So they started really working with staff to understand what is it that people think is important and how are they going to get schemes that will benefit them. And for some people, they said, I just want to be able to cook a meal for my family and I want to be able to do that using fresh produce. For others, they said, well, we really want to get fitter. And it turned out that many of those staff had never left London. So they put on some very low cost schemes around fitness, exercise, health and wellbeing. And they found that they really did manage to improve sickness absence and staff feeling valued. So real impacts on health. And I'm sure many of you have got examples of similar schemes in your workplace. But this lens of health inequalities, how do we make sure that these are meeting the needs of our staff? And if we think about it, for many of us, we'll be employing local people. So at Imperial, over 7,000 of our staff live in northwest London, so they are our communities. So thinking about staff as the local community and their health is really important. So at the end of each section of the pillars, I'll just give a little flag to what that means and what it makes up, because some of these case studies are quite disparate. But in terms of employment as being an anchor, that's both widening participation, that's thinking about who we're attracting from a very early stage, and that once those people are employed, how do we be a really good employer, thinking about all of those things impacting health and well-being. I'm going to whiz through to the second pillar, which is about procurement. And this is about choosing to buy goods and services from local businesses. And that then provides in turn jobs and opportunities, which encourages improvements in communities by supporting individuals that are being left behind, but also about bringing in new investment. And for many of us, particularly who work in the NHS, there's often this thing about, well, it's very centralised. We can't just go buying our toilet rolls from so-and-so down the road. But there is more local influenceable spend than many of us realise in the organisations that we work in. There was a bit of mapping done in a couple of hospitals in the north of England where they looked at their top 300 suppliers and worked out how many of those were local. And then were able to have conversations about, well, once we've got that information, which turns out to be sort of 10 to 20% of our suppliers being local, what is within our influence to be able to change and make that more increased? Colleagues in local government have often been further ahead than the NHS and have been doing things around social value in their procuring for a long time, and there are many examples of that going on. But we in the NHS have been a lot slower to that, although more recently the legislation about social value in procurement has been very helpful. But making sure that you understand where your spend is and what you can influence is really important. One of those places is about things like laundry, catering, etc. And food is a really great example because it touches the environment as well as procurement. And this example in North Bristol of a hospital, they did an audit of all the food that they were currently purchasing, both for staff and for patients. And they looked at the financial implications of switching to local procurement to say all the food we source for all of our inpatients needs to be within a smaller mile radius. 50 miles for them was local. It might be different for you wherever you work and live. And they found that they took beef off the menu and that they were only able to procure locally at a cost of an additional 1 pence a meal, which they thought was extremely good value, and sort of put pay to some of the myths about this is just going to be horrendously expensive for us. So there are opportunities to procure more locally than we think, and it's worth thinking about how we map those out. I want to share an example of Rush in Chicago, who's been instrumental in some of our thinking around anchor institutions and anchor organisations, and they've got a very similar map here with their L service, which is similar to some of our transportation services, and many of you will have seen in England the Jubilee line, which connects Westminster out towards East London, and you can see this change in life expectancy as you go further out along the tracks. They were a large hospital that said, how is it that we're one of the safest places in the country, but yet look at these gaps in health inequalities? What are we going to do about it? And they developed a whole health system strategy for equity. It's really worth looking at. But one of the things they developed was a partnership called West Side United, and they've got these 4 pieces of the puzzle that they focused on, which were around healthcare, around neighbourhoods and the physical environment, around economic vitality, and around education. And it was about hiring locally, living locally, connecting locally, buying locally. One of the interesting things in procurement was that many of the local partners that joined this initiative decided to form a cooperative and have been developing local services for the anchor institutions that have included laundry and other things. And so it's been really interesting to follow some of their journey. And in the UK, and particularly during COVID, there were a number of examples where healthcare institutions set up their own small procurement and supply businesses that included manufacturing personal protective equipment. So when people said this stuff just can't be done in big centrally procured organisations, actually there's great things we can learn internationally, but also stuff that's going on right in our own countries and doorsteps. Worth checking out this article, and I'm going to show you a little slide later, a library slide of some really good resources, but this is one around health equity as a system strategy in the New England Journal of Medicine Catalyst around Rush. So the procurement pillar, both being about how do you shift spend locally, but also prioritising and really monitoring social value in the contracts that you have. Swiftly onto the third pillar of buildings and assets and estates. And there's a number of things that can be done in here. Big capital changes, programmes of work around redevelopment and how we really think about how our buildings and green space is used. Local government colleagues in particular spending a lot of time and focus on thinking about quality of homes and how that can be done in partnership with health and in terms of the land and buildings when there's redevelopment opportunities. But for some of us, we don't have the luxury of resource investment or that scale of work. But there are smaller things that we can all think about doing that include how do we currently use the space that we have and how might that be opened up for communities. I remember speaking to some community groups that walk past our buildings and hospitals every day and say, the lights are on all the time and no one's in there. We'd love to just be able to use a small part of one of your buildings to host a meeting every week. So what is it that we can do that's both big and small about facilities and estates? And what I really like about this work that has happened in Blackpool is they went out and asked local communities what would be the things that make the most difference, and they did a number of rounds of prioritisation setting, and that came up top, allowing local groups, charities and businesses to use the estates when they're not in use. Low cost to many of us, but actually makes a big difference. So I'll share a few more examples, but I'll come back to that sort of how do you involve the community in prioritising in a little bit. This is just a nice international example, a bit more fun, probably out of reach for most of us, but actually the Royal Children's Hospital in Melbourne has become really famous as an anchor in the community. They've included a meerkat garden in the middle of the children's outpatients, and they've started to try and help people think about the hospital not just being a place where sick people come, but lots of school trips come there. They've got cafes, community gardens, and so they've really blurred the boundaries of this being not just a hospital, but a place where communities come in and feel like that's a hub. And there are many other examples, both in hospitals and outside of that, Bromley by Bow in East London being an amazing example of this blurring of the boundaries of our organisations and institutions with the community. I'm on to then the fourth pillar, which is about the environment, thinking about how we as big organisations are big polluters often with the amount of traffic on the road that relates to our services and goods and directly to our staff and commuting. In the NHS in particular, there's been some big strong movement around net zero and many organisations declaring a climate emergency. Newcastle was one of the first, and I remember talking to Dame Jackie Daniels, who's a chief exec there, and said, you know, look, this obviously costs money to change your schemes around in energy, heating, transport, etc. How have you managed to convince your board and create business cases? And she said, look, that is really important, but this is a leadership challenge. I felt like this is important to say as a leader of this organisation, we're going to do it and work out how to make that happen. So leadership being really important. University Hospitals of North Midlands have spent a lot of time thinking about how they go more green in terms of their renewable energy, and that has saved them a lot of money, particularly as prices for energy became more volatile. But what they did do, thinking about the inequalities angle around anchors, is then reinvest a lot of those savings into local schemes, tackling Beat the Cold and helping older and vulnerable people. So how can we think about organisationally when we're picking anchor projects and programs that they might have maximal community benefit beyond what might be initially visible or possible? This is one that always causes a bit of contention when I show this slide, but there's an organisation that decided to really ramp up on how they were going to promote the staff cycle to work scheme, about making sure that staff have the ability to salary sacrifice if they want to buy a bike. And, you know, that has all sorts of great health benefits for the individuals around cycling, and also some great benefits for organisations and individuals around green transport. So on the surface of it seems like a really great no-brainer, good idea, let's go and roll it out everywhere, until you look at the types of people accessing these schemes. And in this particular organisation, they found that almost universally it was doctors, consultants, white middle class people buying Brompton bikes and triathlon bikes. And so therefore thinking about what does that do around inequalities of access to those schemes. So it comes back to thinking about how do we have access for some of these things and make sure we understand some of the unintended consequences, and really have that lens of health equity and inequality in our minds when we're thinking about our anchor practice. So that's the sustainability one, adopting sustainable practice, but also influencing sustainability across the community. And there have been hospitals and other organisations that have influenced local bus routes to make sure that people who couldn't ordinarily access the organisation in a way that they could typically do, other than through things like expensive taxis, have been able to come in and get greater access. So thinking about how do organisations provide an advocacy role around some of that. So loads of stuff here, whether you're somebody that works in a small team or whether you're somebody that's responsible for strategy in organisations, things that can be done at any level with limited or no investment, all the way through to things that do require that, but with lots of examples where there has been return on investment and spend to save examples, and many that exist out there in your work. So the fifth one that then I want to sort of touch on, the fifth partnership pillar, is about partnerships. And I'm starting to bring more now the flavour of some of the work we do at Imperial into that. But we've had a collaboration with a number of organisations between the Trust, the Charity for Our Hospital, and Chelsea Foundation Football Club, which is around reducing inequalities and improving health through some of the access to staff, being able to come out and access opportunities in the organisation, but also around some of the schemes that we're running to get our patients more active and well and fit and ready for surgery. And this is just an example of how we alone can't tackle some of these issues around health and well-being, and really need to look to partners. So the anchor pillar around partnerships is about how do we work better with other partners to do this, but also how do we work better with other anchor institutions. And there are many examples of now networks springing up in different places. This includes Leeds and Birmingham and lots of others who have developed anchor partnerships and anchor networks, and they've done that either with a particular focus, for example, let's all look at employment, or they've done that with lots of disparate types of organisations coming together to work together to share work. And that's happened in North West London Integrated Care System, who've developed an anchor charter and really started to think about, across our diverse anchor network organisations, what are we all pledging to do together. here's also a little framework. If you're someone that likes frameworks like me, you might want to go and look at this. Developed in Leeds, that helps you look at some of your anchor practice and see how progressed you are in terms of employment, in terms of procurement, etc., and gives you a bit of a maturity matrix. And here's the work of North West London ICS that I sort of talked about. How do we work in partnership across our integrated care system and think about what are some of the priorities? And here we've got some around employment, purchasing, buildings, and pledges and actions. And I know Charlene's on the call, who's been helping with some of that work. So there's the 5 pillars of anchor work: employment, procurement, buildings, environment, and partnerships. And many of you will already be doing great work in many of these spaces, but I guess it's just thinking about some of the intersection between those and how you really bring the lens of health inequalities to some of that. And I hope I've managed to help you see that. I want to talk a little bit more about the work that we've been doing at Imperial, the hospital that I work in, where I'm the Director of Population Health. And I know a number of colleagues on the line who are both involved directly in some of this work, indirectly, and maybe new to it. So for those of you who don't know about our anchor work in Imperial, that's a challenge for us to be rectifying, to make sure you do come on and get heavily involved in. So one of the safest hospitals, we have one of the lowest hospital standardised mortality rates. But if you look around, we have huge inequalities in life expectancy and health from different parts of the communities that we serve. And when you ask some of our colleagues, they say, well, that's all very well, but if you show me heat maps of people who have paid for school dinners and stuff, that feels like an important problem. But what am I going to be able to do to tackle that from the role that I sit in terms of the hospital? And it's a very legitimate sort of query from people, particularly in our clinical services. But if we look at our vision, our strategy, etc., we are an organisation as a hospital of 14,000 people across North West London that says that we want better health for life. So really, this is part of everything we want to be doing. And I'm going to just talk a little bit about how we've been going about that. And it's about starting to think differently about our organisation and what we're here to do. We're not just a repair shop thinking about how we patch people up. And I like that quote from Don Berwick about hospitals and healthcare being too focused on being a repair shop. We know what makes people healthy is a whole bunch of things, and around 10 to 20% of that is clinical care and healthcare and access to it. But there's a large number of things that sit outside that. And you could say from a hospital or healthcare perspective, well, those are not things that necessarily we do. We deliver healthcare. But actually, if you think about all the things that I've showed you, being one of the biggest employers, thinking about all the buildings and land that we have, the pollution that we generate, the amount that we spend, you start to see that actually healthcare and all of the other types of anchors, local government and others, can really influence the way in which people experience health in our local communities through how they do their business, through being an anchor institution and some of those anchor activities. And so we developed a health equity framework that's got 4 areas in it. And the final one is about maximising our impact as an anchor organisation in our local community. And there's a blog that Bob Klaber, who's been really instrumental in this work, he's the Director of Strategy, Research and Innovation, and I wrote together on that. So do feel free to check that out. But really, it starts to say, what's healthcare's role in tackling equity and inequity, and how can we do that through the different lenses? And I'm just going to zoom into the work that we've been doing as a trust on anchors. So we have a big ambition. We really want to reduce health inequalities and improve health and wellbeing in North West London by deliberately leveraging our resources through the ICS and with our local and community partners to better support them. And comes back to that stuff that I was talking about at the beginning, influencing the condition in the communities that they find themselves in and being able to transform neighbourhoods, towns, etc., both with and for our communities. And I'll say a bit more about how we need to do that better with communities. So this looks pretty complex. I don't expect you to read it. Those of you with the sort of the glasses, the zooming in, the squints, it's more just to sort of show you that we developed this driver diagram based on those 5 principles that I talked about. And this is about how do we layer on methods. So driver diagrams, for those of you who don't know, is about putting a sort of plan on a page, bringing improvement method to the thinking. So out here, we have a big aim. What are the things that are likely to drive that aim? And then how do we split that up in terms of types of projects and activities that we might do in order to drive that aim? And so here, the idea is a focus on the side that you can see the smallest bits are some of our activities and projects that then drive our ideas and activities about widening workforce participation, thinking about our estates for community benefit, and therefore tackling health inequalities. And having that strong logic about some of these activities feels really important, because there is a temptation, I call it kitchen sink-itis, to say everything's anchor work. We throw it all in, and everything in the kitchen sink is anchor. But how do we really think that golden thread of the project or programme that we're resourcing or spending time on is going to tackle and lead to a change in inequalities or influence the social, economic or environmental factors that our communities live in? So being really purposeful about that, and I'll talk a bit more about that logic in a few minutes. So some small text here, but just the headlines to say we've been trying to work across all of these areas around employment, social benefit, buildings and spaces, our environment work and our partnerships, and that's including examples that I've shared around insourcing our hotel services, but also having a new community recruitment partner who's dedicated for Westminster, thinking about how do we tailor our local recruitment opportunities and remove barriers to some of those people to get jobs in our communities. Reviewing the provision of our supply on our on-site food and shops, and thinking about that across all of our supply, and being easier to potentially do that across some of the services like taxis around our hotel services. Thinking about our big redevelopment plans, how do we open the doors differently to engage and co-produce that, but thinking about our physical spaces, so a community lab that we're developing, thinking about our green plans, and then also thinking about working locally with partners. And I'll say a bit more about those two projects, Compassionate Communities and our 2035 collaborative, in a moment. I've thrown a whole load of projects and programmes, and one could get very caught up in starting to run a big PMO around anchors. And in some ways that would start to bring a bit more structure and systematisation and strategy to anchor work. But what it starts to do, I think, is drift further away from that notion of what we're really here to do. It's about changing the communities and the ways in which we work with them. So we really need to think not just about our wish list of anchor projects and how they're going to tackle inequalities through our project scopes and our project initiation documents, but how we're going to do that with our communities in different ways to some of the ways in which we've done traditionally. And what I like about this framework is it has the 5 pillars around workforce, procurement, estates, environment and local partners, but it also talks about community engagement and civic action. And if I was going away and designing my infographic again around those 5 pillars of anchor, I think I would probably do the same and call this out explicitly as the 6th pillar, so that it doesn't get lost, which has been the tendency from some of the anchor work that I've seen. Now, predating our anchor work, we started to recognise as a hospital that we're not always that good at understanding our communities. We sometimes ask our patients about how they feel about the experience they've had with us. In fact, we ask them all the time, but they sometimes tell us. But actually, how do we find out what people think who haven't yet come through our doors, and those people that sit in our communities that we seldom go and ask or listen to? And so we started working with, a number of years ago, Citizens UK, and took some of the community organising principles from their work and have used that to embed in some of the work that we've done as a hospital. And we've also put that into our quality improvement training. So if you now get quality improvement training from us in the trust, you'll learn about relational meetings, power mapping and community organising. So thinking about how do we go out and listen to and understand those power differentials, and think about the how of tackling inequalities as much as the what, and understand those voices to shape and set our priorities as being really important. And we've learned a huge amount from doing that with Westminster City Council, which I'll tell you about in a minute, through our 2035 collaborative. There've been a number of organisations who've really done this purposefully and systematically. They've gone out and engaged with communities and done priority setting and ranking and looking at, do we all agree that these are the same priorities that we want to start tackling? There's finite resource, finite bandwidth, finite time. What are we going to choose? There's so much that we could do, and there's loads of examples where organisations have really been doing that. One of the things that we're really keen to change is culture around this, and how can we start to think about our staff understanding and thinking that communities are part of the work in which they need to do and have that in their minds day to day, particularly being very busy. And from my perspective, our staff who work in the hospitals, thinking about patient flow and busy EDs, it's a lot to ask to say, well, while you're seeing that patient for their really acute heart attack, can you make sure you think about all the people that live on that estate, you know, 5 meters down the road? And they think, well, yeah, but I'm here to do the job of, you know, helping people within my remit of that work. Well, we've just showed that actually we have a responsibility more widely from much of our work and our populations. And how do we help our staff really understand what that means? So when a patient comes in with an acute illness, or when we're interacting with the resident, that we understand what it means to live in these communities. And I remember sitting in a huge number of staff induction programs, I'm sure you all have too, where you think, well, they're telling me about where to get my ID badge and how I log on to the computer system and the services that we provide, but we know very little about the types of people we're working with and where they come from. So we've instigated a community walk monthly where staff can sign up and go out and see some of the communities, the organisations we want to work more with, and really understand what it means to be the fabric and the anchor in that community. So really trying to change culture. And I really love this quote, and we've heard so many. I've worked for the Trust for almost 15 years, been based at St Mary's, and I had no idea this kind of community was just on our doorstep. So thinking about both the what and the how do we change culture to think about our role as anchor institutions? I talked a bit about how organisations and communities get involved in some of our decision making. This is one example we ran in partnership with Imperial charity called Compassionate Communities, where communities and community organisations, community partners were involved in directing the decision making around where grant funding should go, and delivered over 500,000 grant funds in the first round of that programme to tackle projects and programmes most affected by health inequalities. So really thinking about decision making and governance. Where at the moment do your communities have voice in choosing about where resources directed, where time and energy is spent from organisations, and being much more purposeful about that? And then takes me on to sort of the final part of the work we've been learning through Westminster City Council is our partnership in #2035. And great to hear that we've got lots of people on the call who have either been touched by that project or are starting to become involved in it as a big programme of work, and it's a strategic priority for several of our organisations on the call. But one of the places that I've learned a lot from and have tried to channel into the programme about 2035 is from Rush in Chicago, and I talked a bit about that around making health equity a system strategy and thinking about how we really tackle some of those inequalities. So what we're doing around listening, connecting, amplifying and accelerating our work. And you can find out more about that through some of the wider stuff that wraps around this speaker series. But we're really keen to be a sort of strong partner from healthcare, and we're working much more closely now with others in primary care and others from the health side, as well as with local government, to think about what's our role as anchors in a place across northwest London. How we measure then the impact is really important, and lots of anchor dashboards have sprung up in many places thinking about measurement. This is a nice one that I've seen in Suffolk and North Essex in SNE, where they put all of their hospitals on that and have started to think about benchmarking activities to be able to help people to compare, you know, what percentage of people are we employing from the local area, etc. Now, benchmarking has its pitfalls, and I'm sure we could get into a whole session on that about how do you make fair comparisons, but starting to introduce data to people so they understand their baseline and helping them to think about what is it they want to improve is really important, and measurement is very key. The Rush example from Chicago, West Side United, has been really pushing on the fact that measurement as well as quantitative data to show impacts and changes is really important. And they've got some really dynamic dashboards that they use to show around where investment is moving and changing. And there's more you can kind of read about some of the stuff they're doing. And this is a really nice, different article about the Rush work there. With my hat and UCL Partners, one of the health innovation networks in London, we've developed a toolkit for helping anyone who's interested in measuring anchor activity and creating this logic about the activities that they're doing. And it's centered around those 5 pillars of employment, procurement, building, sustainability and partnership. And you can take a look about that. We had to be quite specific about some of the metrics and measures and their sources. So we picked some of them around NHS trusts, but it's relevant for anyone who's thinking about anchor work, whether you're working in health or care, local government, beyond, whether you're working in an individual institution, an integrated care system, regional level, or wherever you might be. And what it does is it takes you through some of the logic around, if this is the impact we want to have on health inequalities, what might be some of the outcomes we want to achieve, what might be some of the activities and outputs that we need to do that, and what might we need to do that, and then therefore how do we measure it. And there's some examples of baskets of indicators for each of those pillars, and it's a really nice interactive document, so do go and check it out. And here's some of the kind of principles that we developed when we were going around looking at the examples of good practice around measurement, which are really making sure that you're purposeful about equity in that, as well as some of the other pillars of anchor impact around local wealth. Thinking about how you connect with the community, I've talked about that, making sure the community are involved in this work. This doesn't have to be brand new work. We don't all have time, money, energy to be creating new projects. How do you build on existing work and think about putting an anchor lens and pivoting or making things a bit more intentional, being flexible depending on your local circumstances, and then a few other things there. We're almost at the end of my whistle stop tour, but to say that communities and networks, community to practice and networks are really important ways of sharing and spreading learning. I help to chair the London Anchor Strategy and Change Network. We've tried to do things a bit differently, and that's for anyone who's interested in anchor work and is doing local anchor work. And instead of hosting meetings on Teams, we do them in person only, and we go out to places in the community, and usually it's an NHS organisation that partners with someone else. Several times we've had local government partner with the NHS to host us, and then we've gone out to look at the impact some of these schemes and work are having, or look at the local communities and be joined by community groups to hear from them about their work and impact. So thinking about how you run your meetings, where you run your meetings, the governance of them, and the way in which you do the learning and sharing should be a really important part of how you're doing anchor work. So some of my top tips and takeaways finally: what's within your sphere of influence and control, whether you're working in a very small team or project or program, whether you're an organisational system leader, there's something in it for everyone. Make sure you're building a baseline understanding of what you're currently doing. Really try and tap into some of the visible leadership that you can get in the organisation and make this part of what people think is their core work. Really, really proactively engage with communities. This is work that really affects them. Make sure you measure and evaluate, and do support each other and share and spread ideas. I promised you a little library. There's a few things on here that you might want to check out. They then open a whole treasure trove. It's a bit like being on Pinterest, where you click on something around kitchens and suddenly you're in a whole world of pain around all sorts of things around storage solutions. But this is a bit like that. You could click on any number of these types of articles and find a huge number of references that hopefully will be useful and inspirational to you. So at the beginning, I asked you to think about whether you were new to the topic or an absolute expert. Hopefully, if you were completely new or fairly new, you've notched your way up a bit. If you're somebody who's already doing stuff in this space, then you're thinking a bit differently about the lens that you could use around the role of anchors in tackling inequity and inequalities. And if you were already the world leader and expert, hopefully you've got some more examples and you might be able to use some of the ones that I've shared here that might be new to you. So my contact details are just here, but I'd urge you to think about what you're going to do differently. There's lots of webinars, loads of things that you can attend, millions of meetings, I'm sure, talking about anchors in your organisations. But really, what's your role in this and what are you going to do differently? So I'm going to end that, and I'm going to come back to the team and hopefully be able to see and hear you all. Sharma, I think I'm handing over to you. The horrible thing about having no real chat is I can't hear whether people are thinking it's amazing, Dom, that was great, or oh, she's, you know, she's sharing some of the stuff we already know, or I've got another project. So hopefully some of that will come out in Slido. It's hard to do this down the line without audience interaction when you're an extrovert like me. But Sharma, over to you.
Let's just put the chat back on then, Dom, and then if people
no, I don't want to break things. It's my personal inclusion drivers going mad. Absolutely. But I'm sure you've had questions. Go for it. I don't want to break the format.
We've only got 2 questions. I'm gonna read out the first one, and please, people, do click on the Slido link and add your question if you wanna ask a question. So in fact, we have 3 questions now. Great.
Brilliant.
So the first one is, do we have an anchor dashboard in Northwest London ICB to connect to?
Good question.
Go on, I'll let you answer.
Shall I pick some of that up? I think Charlene Alfred might be on the call. If not, I'm going to put her email details in. She's one of the key people that's leading the work in Northwest London, thinking about both the charter and what people are committing to, the pledges, and how those are measured. And I know Charlene and June as well, and Nicola Kay have all been part of our anchor toolkit and measurement work, and have been doing lots of thinking around what are the indicators that make sense at a institution level, at an ICS level. So there's lots of work going on around that. So I'll dig out emails for Charlene and June and make sure that those go in the chat if people are interested. But yes, lots of thinking and work going on in that space.
And if people are outside of Imperial, what's the best way for them to find out more about what you're doing?
Yeah, so the Northwest London work is at the level of the integrated care system. At Imperial, we are starting to use the toolkit to work out our baseline measures as well. So if people want to get in touch with how we're starting to think about measurement from anchors from a perspective of an individual organisation at Imperial, that's me to contact, and I can put you in touch with Liz, Ben, Hannah, Sharon, other people who are doing that work at a Northwest London sector level in the integrated care system. That is Charlene Alfred, June Farquharson and Nicola Kay, who are all leading the work on anchors and health inequalities. So various different sets of measurement going on at different levels of the system. And if you're somebody that works on a programme or project, you might well have metrics attached to that. You might be interested at an organisational level. So it kind of depends where you're working as to what level. But do check out the anchor toolkit as well. It's well worth a look at.
Brilliant. And the next question is, how can we assess our policies and procedures against the principles of anchor institutions? For example, are our recruitment processes encouraging local residents to apply? How are we making decisions about the use of our property and estates? Are we doing enough to proactively support local organisations and to participate in procurement processes?
That is a brilliant question, and one that's quite challenging, because if you're somebody that is interested in this at sort of an overall level, where does that sit? Should we be going out to estates to say, what are you doing about anchors in buildings? Should we be going out to our, HR colleagues and saying, what's going on around anchors in employment practices? And so some of this is about where do we join up the thinking and understanding. Barts Health have an amazing equity and inclusion board where people who are working in different parts of the anchors work come together in their organisation, and they've done some of that mapping. So they've gone away and said, using some of the UCL Partners Toolkit, some of the stuff based on the LEADS framework, looked at the different dimensions and said, right, are we doing basic things like paying the living wage, and almost done a bit of a self-assessment. So there are loads of different criteria you can look at and lots of data you can gather. But I guess one of the things is to say, well, where do we have those conversations in our organisations or at our team levels? And how do we encourage our leaders to make sure that we are asking those questions? So if you are somebody that works in your organisation, you don't know what's going on, have you got an opportunity to ask, what are we doing as an anchor institution in my organisation, in your all-staff briefings, etc.? We had a bit of a debate in my team. There'll be a couple of team members who are probably on about the pros and cons of mapping things out, and they're only ever as valid as the day that you do them. But I do think there is something about baselining some of your activity and understanding what you are doing in terms of your work experience schemes, and making sure that other people in the organisation know about that and make that visible to each other, because I'd love to go out and champion some of the schemes and projects that are going on, but I don't always know about them. So getting better at being more strategic and intentional, understand what we're doing at baseline, sharing that, and then saying, well, what are our aspirations? So once we know what we're doing at a baseline, well, what does good look like in terms of local employment numbers or local procurement spend? How do we have conversations to potentially set some targets around that, or at least say we want to see some improvement and change? And how do we bring people in to help set those priorities? So rather than us in our individual organisations cooking up targets that sound very unachievable, what are we doing to say to communities, out of these set of things, which are the most important to you? Where would you like us to see most progress, as I've kind of mentioned? So it's a great question. I don't have the answers, but I think it is about speaking to your leaders in organisations, looking at your own teams and practice. You know, every one of us probably works in a team. When we did a recruitment for a post, how are we making sure that that was as accessible as it could be to some of the areas of our communities that maybe we weren't expecting or as it envisaging might apply? And starting small and thinking, what's in my own sphere of influence and control? But there are loads of toolkits, loads of mapping tools and other things that you can use to have a look at some of that practice.
Brilliant. Okay, I'll ask you one more.
Okay, great. It's like my specialist subject, mastermind.
I know there's some great ones, and there's also just a lot of people saying thank you so much and what a wonderful presentation.
Oh, great,
and
great.
That they're doing similar work, and they're really excited to hear what you said. Yeah. But there's also one that just says, how do we ensure that community organisations that might also be anchors, for example, youth services, GPs, community centres, are included and protected? For example, if we start to see somewhere like St Andrews as an anchor institution and not just as a youth service, it might change the way we support and engage with them.
Another brilliant question. It comes back to that kind of definition thing. And I think some people can get a bit purist about, well, anchors are only those that are large and, you know, they're only those that are public sector. But I think there's no reason why all organisations can't think in this way. And indeed, the voluntary and community sector, primary care, they may not have large numbers of people that they employ, but they do reach and touch a huge number of people in the community. So they absolutely are rooted and invested and mission driven with communities. So I very much see them as anchors as well. I think there's something about how we think differently about who we partner with. And we shouldn't just be partnering with more of the same types of organisations. So there is a you know, I guess a bit of a tendency to say, oh, I'm going to look at all the other hospitals and we'll partner with all of them on employment for anchors. Actually, no, we should be looking at some of these community organisations that have the best links and the most knowledge about the communities and the types of interventions that work and don't. So it's something that I feel really strongly about, both partnering with communities as individuals, as collectives, and organisations that work with, for and represent communities. And I think that fifth pillar of partnerships really does need to bring that in, and that speaks to the how as much as the what. So it isn't just about the tick list of anchor projects, I'm doing this and I'm doing that and I'm doing that. It's how we're doing it, and are we getting the right people, the voices, the biggest inclusion representation across the piece that we need to, and being really critical of ourselves, making sure that's in our governance structures, in our decision making, in our priority setting, in our consultation, in the ways of where we hold our meetings, who's part of those. So it needs to span everything that we do, Sharma. I think is really important. And thank you for that feedback. It's great that people have enjoyed and listened to the presentation. I would urge you to go back and have a look in the chat. There's so many people on, which is fantastic, and lots of people did put emails and stuff in, so do connect up with each other. But I'm sure we're going to find a way of getting the slides out. Do tweet me either as a direct message or on Twitter, tag some posts and tag some other people in, and I'll do the same to try and make sure that we get a real range of people in the conversation. But it's been great to be able to talk to you, and I hope that has managed to cover the broad range of stuff that is what can anchors do around health inequalities, and set our first 2035 speaker series off, Sharma.